Good morning, good afternoon, and good evening, depending on which country and region you are in now. Welcome you all to the first International Kiss Discussion organized by IAMS. I want to thank you all for your attendance. Um, I would like to take this opportunity to thank all IAMS board members, founding directors, members, volunteer work, committee and committee members, and all international collaborators and colleagues from many different airway management societies. I want to especially thank the um, volunteer group for this case discussion, the host institute, Xijin Hospital in Xi'an of China, and the host, Dr. Zhihong Lu, and the presenter, Dr. Xin Tai, and the expert panel, Ellen, Barry, and Wu Hua, and Klaus Wiedemann. I also want to thank the industry for their support, especially from Touring Well-Lead and UE in China. I would like, for those who are not familiar with IAMS, I would like to show you the video, the introduction video first. again, we would thank all your support in the past, and thank you for your future support continuously. And now I'm going to present today's host, Dr. Zhihong Lu. And Dr. Zhihong Lu is Associate Professor at the Department of Anesthesia in Xijing Hospital, Xi'an, China. And um, Xijing Hospital is one of the IAMS assisted training centers on airway management. And also, Xijing Hospital hosts the IAMS organized IAMM in 2018 in Xi'an. I think many of you been there and enjoyed the meeting. Well, thank you very much, Dr. Lu. Now it's yours.
Thank you for your invitation and introduction, Professor Wei. Good evening and good morning. Welcome to the IAMS virtual case discussion. I am Zhihong Lu from Xijing Hospital. It's my great honor to host today's discussion. And it's great that the case of our hospital could be presented to anesthesiologists of many countries. Our hospital, as Professor Wei have mentioned, is Xijing Hospital. It's located in Xi'an, a city in northwestern China. And it's among the top-ranking medical centers in China. As Professor Wei have mentioned, our department is one of the training centers of IAMS, and we have proudly hosted the IAMS meeting in 2018. And we have been certified as the Airway Management Training Center of Chinese Society of Anesthesiologists. We are running many airway management teaching and training courses. You are warmly welcomed to Xi'an and to our hospital. So let's move on to today's topic. Today, we will discuss a case of difficult airway management in an obese patient with limited mouth opening. The case will be presented by Dr. Chai Xin. He is an attending anesthesiologist in my hospital. And we have invited famous experts for today's discussion. May I have the honor to introduce them. The first expert is Professor Wu Huama. He is from the first affiliated hospital of Guangzhou University of Chinese Medicine. He is a chairman of Department of Anesthesiology in his hospital, and he is the vice president of IAMS, vice president of Chinese Airway Management Society, and faculty of training classes of Chinese Airway Management Society. And we have Professor Ellen O'Sullivan. She is from St. James Hospital and Trinity College in Dublin, and she is the chair of World Airway Management Meeting on 2015 and 2019. She is the past president of College of Anaesthetists of Ireland, and she is council member of Royal College of Anaesthetists in UK, etc. And we have Professor Barry Maguire. He is from Nanwells Hospital and Medical School in Scotland. He is president of Difficult Airway Society, that is DAS, and he is founder of the Scottish Airway Group. He chairs a DAS working group developing guidance on the ethics of airway management and has published widely on airway management. And we have Professor Klaus Widermann from Germany, who is board member of IAMS, and he is a famous expert in the field of airway management. Thank you for your participation. So let's start with the case presentation. Dr. Chai, please share your screen.
Honorable Professor Wei, Professor Lu, and our expert panel, Professor Ma, Professor Allen, and Professor Barry. Good morning, good afternoon, and good evening. I'm Xin Chai from Xijing Hospital. It's really a great honor for me to share this case with you. And today I'm going to talk about difficult airway management in an obese patient with limited mouth opening. And now I will make my presentation from the following 5 aspects. First of all, let's talk about our case. A 57 years old female. The BMI is 30.5. Due to hearing loss in right ear for 5 months with limited mouth opening for 3 months, come to our hospital with a history of hypertension for 6 years. The physical examination showed nothing but the mouth opening for about only 1 centimeter. And the PET-CT showed irregular mice soft tissue lesion in right pterygopalatine fossa. The MRI showed the size of the tumor is 3.7, 3.2, and 2.6 centimeter. From the nasal bronchoscope, we can see the hyperplasia of lymphoid tissue of tongue root. And there is no abnormality in laboratory examination. As we all know that the masseter and the medial pterygo control mouth closure, and the lateral pterygo control the mouth opening. However, all this tissue invaded by the tumor has caused the limited mouth opening eventually. And now let's see the diagnosis and the surgery. This patient was diagnosed as A. Tumor in infratemporal fossa, B. Secretory otitis media. And the surgeon plans to perform the tumor resection under general anesthesia. There is a retrospective study of airway management in head and neck cancer surgery showed that 42.8% of the patients has restricted mouth opening before surgery. So how can we perform the intubation? Visual laryngoscope, ILMA, esophageal tracheal combat tube, visual rigid laryngoscope, or visual flexible intubating scope. Considering that the patient is obese with restricted mouth opening, we choose the visual flexible intubating scope at last. And first, we perform the mask oxygen after the patient entered the OR and connect the monitor. Then we give the patient midazolam 1 milligram and fentanyl 40 microgram venously. We use ephedrine and furosemide nasal drop to. We use ephedrine and furosemide nasal drops to vasoconstrict in nasal mucosa to avoid bleeding. And the tetracaine for surface anesthesia of tongue root and nasal mucosa. And we performed therapeutic with 2% lidocaine for surface anesthesia of vocal cord and subglottic.
闭眼睛就可以啊，闭眼睛，病人。闭眼睛。
仰头，
仰头，仰脖子。
脖子要仰起来。
To export the
放松。咳，使劲咳，使劲咳啊！对，很好啊。好，好，特别好。
After that, we use an epidural catheter to inject 2% lidocaine for surface anesthesia of valvular epiglotticus, and the vocal cord.
好，喷，喷完了吗？
水喷完啊。
喷完。
And now we had finished the surface anesthesia. When the tongue root, epiglottics, and molecular epiglottic were anesthetized, the glossopharyngeal nerve and the superior nerve were blocked. And the recurrent laryngeal nerve is blocked after the vocal cord was anesthetized. Then we performed the intubation with the visual flexible intubating scope. Then we fixed the tube. And this is the video of the patient breathing autonomously after intubation. And finally, the operation lasted almost 7 hours, from 9:45 a.m. to 4:15 p.m. And the surgeon performed the open right maxillary sinus, partial maxillary resection, infratemporal fossa tumor resection, and the right tympanic membrane incision and the catheterization. From the video, we can see that the patient's mouth opening was improved.
Okay.
And the mouth opening was improved from only 1 centimeter pre-operation to 2 centimeter post-operation. And the pathology result was meningioma. There is no tumor recurrence were found on MRI 9 months after the surgery. To sum up, sedation and opioids should be used continuously in obese patients awake intubation. Adequate surface anesthesia is the key to successful awake intubation. Indications for extubation in obese patients with difficult airway should be much more stricter, and there should be a pre-plan for airway obstruction after extubation. Is there any more choice for these patients? The high-frequency jet ventilation, thrive, or retrograde intubation? Thanks for your listening and suggestions. That's all.
Thank you for your sharing your case. And next, Professor Wei will take us through the alternative intubation technique of this case. Please share your screen.
So first, I have some financial disclosure to show this video and information. I am inventor of the wind needle jet tube that generates superglot jet oxygenation ventilation, SGOV. I'm also a consultant of well-lead company, which made the wind needle jet tube. So in our hospital, we have a lot of patients called TMJ, or temporomandibular joint syndrome. I think in Western countries, a lot of this patient. We use this kind of patient, like showing in this picture, this limited mouth opening, about 1 centimeter. This is like a permanent chronic. They cannot open the mouth. And then we used to use a weak nasal intubation. because this, if you have a difficulty or bleeding and you kind of put a blade in, it will be difficult to manage. But since the use of FGOV, I have in majority of patients of this kind of patients use FGOV through one side of the nose and a nasal intubation through the other side of the nose. In the next video, you can see the whole procedure, how to use HGOV assisted nasal fiber optic intubation in a patient with limited mouth opening. Be pay attention to follow point. One is how do I set up HGOV, and also the patient is actually generally severe under intravenous topical infusion and fully paralyzed. Actually, when you paralyze patient, the vocal cord open, the FGOV is more effective to get a chest rising. The other thing, I typically expose the chest and stomach so I can see the chest rising. If you use the real nasal jet tube, then you can also monitor CO2. I just use a regular nasal cannula with a suction catheter connected to the manual jet ventilator. But the exposed stomach to see whether sometimes, very rarely actually, I think less than 5%, you can see the stomach going off. The recent study has not been published that when the driving pressure of ejaculation PSI over 30, then you have increased risk of gastric expansion. And most of the time, very rarely, but I do expose it. The other thing, I prepare the suction ready. The Because the nose bleeding is a major issue when you do the nasal intubation. And also get a backup plan for the surgeon. It be there in case nose bleeding and a difficulty, whether you need the stat from that technique for emergent airway. The other thing is I don't usually use this technique for obese patients, like more than 100 kilo, although doctors have his BMI 30, I would say it's fine for this technique. BMI 30 in US is really not considered obese patient. So if it's more than 100 kilo, I'm just worried about it. I'm not confident. The other thing is if you use this in this kind of patient, you want to be familiar with technique in the elective case, practice yourself before you use it in this kind of real difficult airway patient. Otherwise, if it's some bleeding and issue, you don't know how to manage it because you're not familiar with the technique. I did have one case that has significant nose bleeding during the nasal intubation and SCOA, but we just put a suction catheter and keep suction, keep jet ventilation, and keep going until we successfully finish the nasal fiber optic intubation. So next, I'll show you the video in the real patient. You can see it's how SGOV support patients the oxygen ventilation in a paralyzed patient for more than 3 minutes and get the nasal intubation successfully complicated in this kind of patient.
I would
take this vertical.
0. Okay. What kind? It's like a. Okay.
Let's see, let me see chest rising on the just one moment. You put chest rising, you see that chest? Don't, yeah, let me see.
Shall I include it?
Yeah, a little bit inside or you pull a little bit in or out to make sure the chest rising is on the good side. Okay, I think this is good. And take your tubing, put the tubing in the left nose. Put tubing first. So I'm often, you see the chest rising? I'm often the patient. Slowly, I don't get bleeding. The major is bleeding. Okay, thorough. So here's all, you see the chest rising very well, right?
Mhm.
Yeah. You need a, vertical to the patient's body, yeah. Slowly. There's a pump. This probably should have a pump, but here's ventilated. Slowly. Don't get bleeding. But here's ventilated. So don't take your time, okay?
Liz,
Don't rush, don't get these.
you know what I mean? Like, is he like a trapping on this?
Yeah, I think
Is this chest rising, right?
Yeah. Good chest rise.
Okay, that's good enough. And put a scope in. Fiber optic scope now. It's ventilating very well. Yeah.
So, I'm gonna warn you guys.
No.
There's teeth and the scrub roll.
All right.
And for sciences.
All right.
I'll
Do your best.
Bleeding? No. You want a little bit, just a little. Going. She's still ventilating well, chest rising well. Pull back a little bit. Yeah, you have to orange it yourself.
one last thing.
You know what you want.
We'll have to get
Yeah, that's it.
the science.
Maybe it's obvious.
There you go. There's vocal
Here you are.
Basically
Vocal
do a
cords.
canister.
See the ventilating is a.
And it'll have.
No, I put back a little bit. See the
Yeah,
ventilating.
there you go.
It's like a tissue
Where the
strap.
vocal
Sits
cords?
on the canister. and
I didn't see it clearly.
I did.
If you don't see it clearly, pull back.
Tricky.
Where's the epiglottis? Look at it.
Yeah,
Is this a
you're in
second
the-
already? Oh, okay.
yeah, you're in the-
Wait.
you're in the
When should
tricky.
see finer?
You know where all the cotton.
Okay, that's good. Okay, that's good. We see finer. Okay, that's good. Put the needle tubing, please. Okay. Okay, that's good. You see that he keeps alternating. You have good chest rising. See. So that's the case. Thank you.
Thank you, Professor Wei. And Dr. Chai and Professor Wei has provided much information about this kind of cases. Now, let's move on to the discussion. The teaching and learning points of the case discussion include, as was shown on the flyer, first, pre-anesthesia evaluation and plan. Second, awake fiber optic scope intubation in obese patients. Third, alternative techniques for tracheal intubation. And the last one, re-intubation during emergence and after surgery. What's your opinion with regard to these 4 topics? Professor Ma, would you talk about your experience?
Oh, okay. Thanks. Hello, everyone. Good morning. Good evening. Dear Alan, dear Professor Fa Hongwei and Professor Lu Zifeng and Cai Xin and Whiteman and many. I'm Wu Hua Ma. I come from China. I work in the first affiliated hospital of Guangzhou University of China Medicine. I'm also vice president of International Airway Medicine Society. It's my great honor to take part in the case discussion. Firstly, I want to thank Professor Fafeng Wei, who is also the president of IAMS, organizing the wonderful case discussion. I also want to thank Dr. Tsai, share a wonderful obese case with limited mouth opening. You and your teams did a fantastic job. I'm sure we can learn a lot from the case. Oh, okay, let's get to the point. I will share a little experience about obese patient with limited mouth opening. Before operation, we should assess whether the patient has metabolic syndrome or other comorbidities, such as ulcers, diabetes, and hypertension, especially for the patient BMI is more than 50 kilograms per square meters. Before operation, we should also evaluate the patient leg circumference, aspiration risk, BMI, and mouth opening. Because the patient suffers from limited mouth opening, so is anticipated difficult airway. According to the guideline, awake chicken intubation is the first choice. It is the golden standard for the case. Of course, you can use another choice like Professor Fafeng Wei used. So I think Dr. Tsai and his team made the right decision making. In order to make a successful awake chicken intubation, I will emphasize some key points. The first step I will emphasize is, for any cases, the administration of supplemental oxygen during ATI is recommended. If available, high flow laser oxygen should be the technique of choice. The second step is to keep patience. Before conducting the ATI, we should prepare everything in advance, including staff, monitor, various airway devices. The third step I will emphasize is that the use of anticholinergic drugs is recommended in the form of awake chicken intubation. It can provide a clear and dry airway, protective against the risk of aspiration, and enable adequate hospitalization of airway. The fourth step I will emphasize is sedation. Awake chicken intubation may be safely and effectively performed without sedation. However, its use during ATI can reduce patient anxiety and discomfort and increase procedural tolerance. In our department, we prefer use lamivudine and dexmedetomidine alone because the two drugs are associated with high level of patient satisfaction and the low risk of oversedation. Dexmedetomidine causes minimal respiratory impairments, even at high doses. The fifth step I want to emphasize is stabilization. The success of ATI depends on effective topical application of local anesthetic to the airway. For the nasal mucosa and the nasal pharynx are highly vascular. Vasoconstriction of nasal passage may reduce the incidence of epistaxis, as bleeding in the nasal cavity can make visualization of the larynx extremely difficult, especially during V-phase intubation. In our department, we also use 2.4% lidocaine to spray above at below vocal cord, while epidural catheter and working cello of V-phase. The sixth step is ETT choice and the route for ATI. It's vital to choose appropriate route for tracheal intubation, visualization device and tracheal tube. Because the patient with limited mouth opening, the laser approach is the right option. The V-phase is the preferred device for the case. So I will remind the appropriate equal mouth ETT. It means park ETT with the size 6 to 6.5 should be taken into account to prevent epistaxis. Of course, if there is low V-phase, there is low fiber scope, retrograde intubation is also alternative method. If ATI is unsuccessful, one should ask for hope. It's very, very important. And ensuring 100% oxygen is applied and post-op ablation or emergency frontal neck access. We all say FOLA, including chronic thyroidectomy or tracheostomy. As for extubation, patients who have had ATI due to anticipated difficult airway management are at high risk of complication and tracheal extubation, and acquire an appropriate tracheal extubation strategy. A BUCH or AEC, airway exchange catheter, put in the ETT in advance is the prudent choice before extubation. Of course, if the patient BMI is more than 50 kg per square meter, we should consider more aspects, including metabolic syndrome, diabetes, pre-oxygenation, and the limb position. Is my comment. Thank you.
Thank you. And what's the opinion of other experts? Professor McGuire, would you please share your experience?
Yeah, lots of points there. Professor Ma has made most of them, to be honest. Congratulations on a very well managed case. My first observation would be this is very clearly a case that requires awake tracheal intubation, and that was what was performed. So I agree with that, and I think that's the key, that we try to perform these cases awake. Professor Wei has shown us an alternative, but my personal opinion is that that alternative should be restricted to people with the expertise to carry that out. And Professor Wei made that point. I really wouldn't want to encourage most of us to be delivering general anesthesia on patients like this without securing the airway first. And that even includes if awake tracheal intubation is unsuccessful. I would not recommend that you proceed then to general anesthesia intubation attempt. We know from various data collections that that is a high-risk maneuver. So if you fail with awake tracheal intubation, it should be reversible in terms of sedation. You should be able to stop and then think, perhaps get somebody else, perhaps do a retrograde technique, whatever it is, but keep the patient awake. At the same time, having had a communication with your surgeons with regards to airway rescue, if it came to that in terms of potentially over-sedation. I absolutely agree with Professor Ma that I personally would recommend single agent sedation for conscious sedation. I think combining opioid and benzodiazepine increases your risk of oversedation and loss of cooperation, albeit in this case, they used very small doses. My questions to the authors or the presenter really there, Dr. Chai, would be, was there supplemental oxygen given during the awake tracheal intubation? I didn't see any, I wasn't aware of any. I don't know if Dr. Chai can answer that. And he's not there.
蔡医生，你有没有在清醒插管过程中给那个供氧，给病人供氧？你 on mute.
I forgot to click the voice, and I performed the max oxygen when the patient entered the OR, and we gave oxygen during all my steps, maybe 5 liters per minute.
By which route?
By the mask oxygen, and the patient can brace herself.
Yeah.
She's awake.
Sure. When you take the mask off to do the procedure, though, there's no oxygen going in at that stage.
Next stage.
During the fiber optic itself, the mask has to be removed from the face. We would recommend continuous oxygenation during the flexible bronchoscopic intubation.
你清醒插管的时候，面罩是要拿下来的，没办法。
Yeah. Yes.
And if you have access to high flow nasal oxygen, the benefits of high flow are several. First of all, it's the best oxygenation technique. Secondly, it helps to disperse your local anesthesia more distally in the airway. And thirdly, it physically opens the airway, the airspace. If the airspace is compromised at all, the additional pressure from high flow oxygen will actually open the airspace and give you better visualization.
Yeah, maybe Israeli is a good choice for these patients. Just the transseal, homodified, rapid insufflation, ventilatory exchange sterile from the nose. Maybe it's a good choice.
I think in China, many hospitals not available.
No.
In the OR. So they're majorly for research now, not like practice for every patient.
Yeah.
So I think that's a good, definitely a good use high flow. Especially obese patients, I think several studies show that. In an OB patient, obese patient, this will give you benefit to maintain oxygenation, especially when the BMI is 50 or 60, definitely.
Professor Wei, I read from papers that with the high flow approach, the oxygenation will be, we can keep the oxygenation for over 30 minutes in patients with apnea. Is that true?
Yeah, those pioneer study, I think very probably Ellen is expert in this area. Those the pioneer study from ENT Hospital in England, that in London, that in the difficult airway in the patient with laryngeal cancer, those kind of patients, difficult airway, they use high flow, and they paralyze patients on average. Apnea oxygenation that prescribed is 21 minutes. I think the longest one is more than 70 minutes without the patient breathing effort on the high flow. I think Ellen has want to say something there.
Yeah, that's absolutely true, Professor Way. But I think that study was in patients who were paralyzed having operations. So that was called Thrive because they were paralyzed and getting apneic oxygenation. I think in the context of awake fiber optic, the patient is breathing. But the same group from Guy's and St. Thomas's, led by the author Imran Ahmed, he wrote a paper using high flow nasal oxygen for awake tracheal intubations in a group of head and neck, very bad head and neck patients with stridors and with comorbidities, a bit like the case that we heard presented today. And they showed there that even patients starting off with low saturation because of their pathology, the oxygenation improved throughout the awake fiber optic intubation with the use of continuous high flow nasal oxygen. Especially, we particularly use it in the high risk patients with stridor, with tumors that are invading maybe the larynx. So I think it's a very good adjunct, but we do restrict it to the patients who have pathology in the airway. For a case like yours, Professor Wee, which was just the TMJ joint mechanical problem, you probably is not maybe as necessary. But this case that was presented today, I would suggest, is a high-risk patient because you have trismus, but you also have a big pathology in the infratemporal area. So that makes it much more risky because that jaw will not open even with relaxant. So, you know, you have your backup plan will not include a G area. Your backup plan, you will not get any further opening of that jaw probably. And that's very important. And we see a lot of max fax patients with trismus without pathology, which is very different from this head and neck type of patient with pathology there. So I think when you're assessing these patients, you always need to find out if the jaw is kind of mechanically obstructed by a tumor, for instance. And secondly, I think the author mentioned, Dr. Chai, when he was presenting, that the patient had a nasendoscopy pre-op, and the nasendoscopy showed tonsillar hyperplasia. Now that's not uncommon. There was a paper by Obese many years ago saying it's very common in the population. And that is a problem because there is tonsillar tissue in the vallecula. So that means putting a scope, particularly a video scope or so forth, in that area can cause bleeding as well and cause the intubation to be more difficult. So there's all sorts of reasons in this case where the only option is an awake fiber optic, in fact, not awake video, awake fiber optic intubation is your only plan. And getting back to something you mentioned earlier, what's your backup plan? When you make a plan, you prepare, you must have your plan B. What happens if you get laryngospasm or if this awake fiber optic isn't successful? Your first point is to always postpone if that's possible, because you can always do an elective tracheostomy or something, so you can postpone and rethink what you're going to do. But if the patient gets laryngospasm, you then, or any other, starts to bleed and you have desaturation, you have to have your plan B. And again, I would suggest in this patient, you might consider, I mean, I think a GA would be very, very high risk. Even at the end, you only had 2 centimeter opening, plus you have a repair here, you have edema from the surgery, which took over 7 hours, okay? So that patient is very much at risk. I'd be very reluctant to put that patient off to sleep and attempt to intubate orally. I think it would be almost impossible. So I would think the only approach would be a front of neck approach. And I also noticed that the authors did a transtracheal injection of local anesthetic at the outset. So they have located the cricothyroid membrane. So they know where it is. It looked relatively easy to access in, you know, a nice thin neck. So I think that patient should be prepped at the beginning, or sorry, at the end, for a front of neck approach if needed. Or equally, I would be talking to my surgeons in that case and saying, please, should we do an elective tracheostomy at the end of this case, because I've big pathology here, you've done surgery there, it could bleed into the airway. I've only got now 2 centimeter opening, and I would suggest that the safest option there might be to do an elective tracheostomy, or else be prepared to do an elective front of neck approach if the patient gets spasm at the end or starts to bleed. So but all the other points made were excellent, and I think it was an excellent case to discuss. Thank you very much.
Yeah, I have several points of view and discuss here with you, and this is an excellent point from Barry and Wuhan and Alan. First, Barry said that the high flow can make it increase the nasopharyngeal pressure that help fiber optic intubation. Yes, that's because it's push the tongue up, and give you more space. You can see the vocal cord earlier, maybe find a vocal cord quicker. And this is also same as SGOV. A lot of times when we do SGOV, and because of the jet pulse, you can see the epiglottis like a valve, like moving around. So you know where you can find the vocal cord quickly. The second, the laryngospasm, those I have when I was in an ASA meeting and present an abstract on HAOV and difficult airways to one of the colleagues from New York Hospital, and he asked, he has a patient with obese, and then the oropharyngeal cancer and a very difficult airway. They did a week fiber optic intubation, and then the patient had the larynx. Eventually, the patient died. I just see whether those are important because on activation, you have a bleeding, you probably have that larynx, have a risk of larynx spasm, and then you have only mouth open 2 centimeters, and it's difficult for put a bleed in. And what happened at that time? I think the major issue when and at what time and when you can push the muscle relaxant. So when you push muscle relaxant and the patient will not breathing, then you're going to have a way to maintain the oxygenation. But when you don't push the airway, patient desetting like it's to the dangerous level, like below 30% for 3 minutes, get a brain death. And what time should you push laryngeal, get the larynx, resolve the larynx spasm first, and give oxygen, either use mask or use jet ventilation, use high flow, and don't get a patient get a brain death, hypoxemia level. And those are probably important question and a backup plan. And I think this kind of patient get a surgeon in the room, and they are the just coordinate with them in case anything wrong. Just get an emergent airway. They can do quickly. Do emergent airway. Those are final backup plan. And I think if you give a muscle relaxant, the risk is if you can't give oxygen, that's basically you need an emergent from that technique for emergent airway. But if you don't give the vocal cord is closed, hypoxemia is if you're propofol or not. Even if you give a propofol, it's probably not, if it's obese. If you give enough, it's probably not breathing well. And also hypoxia will occur. So what's your opinion about those? If it's a larynx spasm, either before, during a weak fiber optic intubation, or in this patient, after activation, has the larynx spasm. And another point is you might think about put a tubic changer through the tube, and then you take out nasal tube. If there's something wrong, you can quickly place another tube, follow the tubic changer. And because you have tubic changer in the chest here, I think what is your opinion from the expert and all the audience about this? If it's a larynx spasm, what should get a backup plan and or backup plan 1, backup plan 2 or 3, and we should go. If you don't think about it when it happens, then the patient might easily get a better outcome with this kind of patient. Yeah.
Yeah, please.
Thanks, Ho. I think, yeah, laryngospasm. I have never seen laryngospasm at awake tracheal intubation. I have seen it at extubation. So before we get to laryngospasm, I would agree with yourself and Professor O'Sullivan that actually in this case, when I hear it and when I I'm aware that it's a 7-hour operation. I think statistically, extubation is probably more dangerous than intubation, especially if you're carrying out the intubation in a truly awake, conscious sedation case. You can't do that at extubation. Well, you can try to do it, but you don't quite know where you are because the patient's emerging from anesthesia. So I think the point that's been made by others, which is that extubation needs as much attention as intubation, if not more. I would be using an extubation aid of some description, like a wire or a catheter, left in when I remove the ET tube as a conduit for reintubation. I would also discuss front of neck access, as Professor O'Sullivan raised that point, with the surgeons. Should we preemptively be changing this tube to a tracheostomy for 24, 48 hours to make sure that this patient is safe in the postoperative period? Depending on where they're going and who's going to be looking after them, there may not be the skill, equipment, expertise, and time to save this airway if this patient deteriorates postoperatively. In terms of laryngospasm, I have a very low threshold. I don't have any problem re-anesthetizing, re-paralyzing as soon as I think oxygenation is ineffective. So if I'm not delivering oxygen effectively because of laryngospasm, I'm going to give anesthesia and paralysis to try to re-establish oxygenation. There is no benefit from spontaneous ventilatory effort if your airway is obstructed. So the fear of giving muscle relaxant, in my view, is an incorrect fear. You should be treating the laryngospasm immediately if ventilation is impossible, and you can take over ventilation by whichever means. But that might involve, at the same time, getting absolutely ready for emergency front of neck access. And as Professor Sullivan says, having located the cricothyroid membrane, that would be your choice. Thanks.
I think Professor Widerman has something to say.
Thank you for the invitation, but I'm not quite sure whether I can add substantially to this issue. My question in general would be, why do you think of jet ventilation for the induction of anesthesia or intubation, at least, in those patients? We must, if this is an issue for preserving oxygenation, either one should think of a more prolonged pre-oxygenation phase, as we didn't see that, I think, in this presentation. And we possibly should give high flow oxygenation, but although I'm a fan of jet ventilation, I should be a little bit reluctant to apply by jet ventilation comparatively uncontrolled amount of air to the airways and to the esophagus at one time. And so possibly there is a discussion of how to manage regurgitation when you when you administer too high flows, and especially jet flows in these patients. So what's the use of let's say of the supraglottic jet ventilation in those patients with undefined or with undefined airway?
Okay. I noticed that in the case of Professor Wei, the patient looks more comfortable and calmer than the patient in Dr. Chai's case. And, dear experts, would you please share your experience on how to do topicalization during awake intubation?
Thanks. I'm happy to say a few things. First of all, the positioning of the patient and the operator is different to what most of us in the UK would be doing. We would be recommending sitting the patient up and facing the patient during topicalization and during the procedure. And the benefits of that are the airway is in a better position when it's upright or semi-recumbent. The patient is looking at the operator and hopefully gaining some confidence from the fact that they look calm and happy and they're able to pause at any time. And then in terms of the topicalization, we would use a malleable, so a bendable plastic device that can be inserted even through very small mouth opening or nasally. And it can be sprayed in an atomization spray. So it gives some spray onto the mucosa, but the rest of it gets inhaled by the patient. And if you ask the patient to take a deep breath, that local anesthesia will pass all the way down to the lower airway. So the mucosal spray is meant to be an upper airway topicalization technique, but if you apply it with deep inhalation, it actually becomes a lower airway technique, and there's no need for cricothyroid puncture. And in fact, there's not even any need for spraying with an epidural catheter down the fibroscope, although I usually recommend that our trainees do that anyway. But if you use a malleable device, bent and gradually introduced round the corner until you're down to a laryngeal level with deep inhalation, you can anesthetize the whole airway with this technique. And it doesn't involve putting any metalwork or large devices in the nose or the mouth. It's very well tolerated. You're facing the patient. You take your time, very small volumes, so they're not gargling and swallowing, they're just inhaling. I don't know if you have access to these malleable plastic atomized spray devices in the places that you all work, but ask about them because they are a game changer. They're fantastic devices for topicalization. Thanks.
Can I just make a comment there? Totally agree that the MAD devices are excellent. Dr. Chai, you used a combination of techniques. You'll have to be careful with your maximum safe dose of local anesthetic. We suggest 9 milligrams per kilogram is the maximum safe dose of lignocaine you should use. And a bit like Professor Maguire said, if you're doing an injection as well as spray as you go, as well as spraying, you'll probably maybe overdo it a little bit. The I think cricoid injection works really well. But if you use that, we don't use our epidural catheter. We use it on patients, again, without pathology, because we don't want to put needles around here if there's cancers in the airway. But for just our TMJ, we teach our trainees to do that so that they can learn to locate the cricothyroid membrane. So that's a good technique in the non-pathology, mechanical kind of difficult airways. But again, we also use spray as you go to teach the trainees to spray past the cords. But with that device that Barry mentioned, you don't really need to do the spray as you go. But again, be conscious of the amount of lignocaine you're using, that you don't overdose on lignocaine, because you can do that. So with the patient's weight, look at the maximum safe dose, 9 milligrams per kilogram. Thank you very much.
I saw Dr. Tay use a epidural catheter for topicalization. Is this a common practice in China or other part of the country, or other countries or regions? And can you use it in a pediatric fiber optic? Maybe Professor Wu Haoman, you have a comment on is it a common practice in China, or I don't know whether in other countries. I never used it in my practice before.
Okay, thanks. 10 years ago, maybe 15 years ago, we used combined 5-scope and the epidural catheter to anesthesia to do the stabilization of the airway. Because so maybe 10 years ago, and we established the CTM to do the stabilization of airway. But maybe in 2010 years, we use the catheter insert the working channel, and because in the tip of catheter there are three holes. So and when you inject the lidocaine, it can spread along the airway. So I always told them we should because when we want to do a comfortable awake treating patient, we should solve 3 key points: is vomiting, is vocal close, and the choke in the airway. So if you want to solve this key point, we have to stabilize the 3 nests: glossopharyngeal nest and superior laryngeal nest and the recurrent laryngeal nest. And if we stabilize the glossopharyngeal nerve and the patient have low vomiting, and if we anesthesia the superior laryngeal nerve and the patient's vocal cord cannot close, and if we stabilize the current laryngeal nerve and the patient cannot choke, cannot eat. So and in China, a lot of hospitals use the method to stabilize the patient. Of course, we use vaporizer. We also use vaporizer, and we ask the patient to open your mouth. Sometimes have limited mouth opening, and we can use the vaporizer to because there is a small tube, and we can insert the small tube into the patient's mouth and then, but it can stabilize the vocal cord. It cannot stabilize the airway below the vocal cord. So we have to combine epidural catheter and working channel of video flexible intubating scope. So in my department, it's a routine work in my department. Thank you.
Thank you. And Professor Mar, I know that you have designed the ABS process for difficult airway. Would you please introduce the ABS protocol?
Thank you. Thank you. It's a good question. In 2008, I designed ABS algorithm because it has the advantage of safety, quickly, and availability. And it's very easy to remember, ABS. So it's very popular in China. I was honored to be invited to make lectures about ABS algorithm nearly 400 times around the world. A is very simple. A means ask for hope. It's very, very important. Ask for hope. Because if 2 or 3 staff to manage the patient with the airway, the patient is safer. B means breathing, ventilation. S have 3 different millions. S1
we have some technical issue. We have some technical issue. I can't hear. Can you hear me?
We can hear you.
I can hear you.
The Professor Wuhama lost the signal. Okay.
Yeah.
And what I recommend is that the live broadcasting can be stopped. Oh, Professor Ma come back. And live broadcasting maybe can stop in the 8:30. Then after that, I saw a lot of new people here. Then they may have a chat to know each other as a friend. Yeah, Professor Mark, you continue? Yeah.
Oh, okay. Samson has gone wrong with my internet. Oh, okay, I will finish it. I have said S has three different meanings. S1 means spontaneous breathing. S2 means STEM, CTM. S2 means surgical airway. So for anticipated difficult airway, what we have to do is let the patient to keep spontaneous breathing. It's very, very important. Then we can intubate the patient in a rigid time with all kinds of airway devices available in your department, such as you can use video flexible intubation scope, you can use video scope, you can with bougie. If you have low this kind of advanced airway devices, you can perform retrograde intubation because the patient has spontaneous breathing. For unanticipated difficult airway, it means you have used propofol, fentanyl, and muscle relaxant, and you cannot see anything. You can not see the vocal cord. What you have to do is perform B, breathing. You can use all kinds of scar, supraglottic airway to ventilate the patient. If the ventilation is adequate, let the patient recover spontaneous breathing is the safest method. Of course, if ventilation is failed, intubation is failed, it means CICV occurred. The last resort is to perform S2 and F3 STEM CTM or do the surgical airway. That's all. So I hope more and more young anesthesiologists can use ABS algorithm to help more patients, to improve patient safety. Thank you. Thank you.
Thank you. Any other comments from our experts? Please.
Just going back to awake tracheal intubation with a flexible bronchoscope, one other thing that I would recommend, or two other things I might recommend, would be the use of a soft suction catheter after topicalization, which will remove all secretions, number one, and number two, it will test the efficacy of your topicalization before you go in with a fibroscope. So I would always suction the airway with a soft catheter, nasally usually, sometimes orally, and remove any secretions and be confident the patient had no gag, no reactivity. So the fiber optic should be straightforward thereafter, certainly in terms of topicalization. Unlike in the video, my recommendation would not be to pass the ET tube into the nose until you're at the carina with the flexible bronchoscope. And the reason for that would be it's an unpleasant part of the procedure, but more importantly, it can cause bleeding passing that tube. And I don't want to do that until I'm at the carina with the fibroscope. So our ET tube would be on the fibroscope, but not in the nose until we're right down, and then we'd pass the ET tube with the tip of the tube anterior all the way down as it railroads over the scope. With the tip anterior, it is in the concavity of the bend. The tip is at the front, so it's less likely to catch. And when it reaches the larynx, the tip is furthest away from the arytenoid cartilages, which are the commonest place for the tube to be held up. So tip of the tube anterior all the way down gives you the highest first pass success rate when you railroad your tube. So that's my 2 tips for flexible bronchoscopy: is use a suction catheter and take care in performing the railroading of the ET tube. Don't just twist it in no direction. Have a technique where the tip is anterior. Thank you.
I have something. Let's imagine this is the patient has limited mouth opening, and also morbid obese, like the 200 kilo, 500. Also in the ICU, the patient is destatting. They call you for an emergent airway. And this is probably the dream. It happened in my hospital, those kind of things. What do you think, what we should do from the expert panel here? And also we have the ENT expert from Ukraine, Dennis, and we have an expert from Ross from South Africa. I'm not sure about Richard and Matthew. Any of you, yeah, Matt, what in this situation, if it's kind of extreme situation, what we should do if this happens? Yeah, Max, I think you want to talk. Yeah, Max from Ukraine and one of the leader in IAMS coordinator training center.
Hello, everybody. And as we all see that 2 cases were near perfect or brilliant management as elective cases. But all our discussion was focused on some case that could be complicated. For example, it could be like emergency intubation with some hypoxia like from COVID, or with some problems for tube insertion when, for example, the size of larynxes does not allow to move tube freely. So I would point out a few practical points. For example, US leader in emergency medicine, Scott Weingart, several times underlined that decision conicotomy or tracheostomy could be made not at once, doing or not doing, but it could be made gradually. Come up to such procedure in emergency cases when such a decision is quite hard to conduct. For example, if in the first case anesthetist make some puncture of cricoid membrane to anesthetize vocal cords, it could be anesthetize the skin for incision. And some emergency physician propose to use some adrenaline in such anesthetize of skin to avoid massive bleeding. It's open questions. Let expert express their opinions whether adrenaline and skin anesthetize applicable in such case, for example, in emergency case or semi-elective or not. The second point is if it will be considered or not considered tracheostomy. It could be some indications, a place for tracheostomy as well. For example, in such big guys over the 40 kilograms per square meter. And it could be also anesthetized with adrenaline. The second step to come up with front of neck, as Ellen always advertising this safe approach, is to have, if patient oxygenation is already compromised, it could be make some skin incision without incision of membrane, or without come up to tracheostomy, but skin incision, and put some pressure to stop bleeding. It's the second step. And if progress with bronchoscopy wouldn't be successful, even taking some tips from Professor Maguire, if such, let's say, oxygenation could be achieved with in front of larynx, or even in the entering of larynx, but the passage of tube could be impossible for a moment if local anesthesia already done, if skin incision already done, if bleeding already stopped, the decision for conicotomy or for some lower approach for tracheostomy, would be much easier rather than to have such decision when saturation is less than 60 or less than 50. So let's for a few minutes discuss some open questions. Would you agree with such small steps approach for front of neck or not? Thank you very much.
Thank you. And other comments?
I'm happy to answer, but I've spoken too much. How about somebody else? Ellen, do you want to answer that?
I see Ross there. Ross's hand is up. Will we? Ross, do you want to comment?
Sorry, thank you, Ellen, and Ellen, nice to see you all. I was actually going to make a comment on Feng's original question about a difficult airway in an out-of-theatre situation in an obese patient. I have got some thoughts on that, but perhaps people would like to just talk about these ideas that have been raised about the front of neck access first.
I think I mentioned that you should always be prepared to do a front of neck approach. So putting local anesthetic with adrenaline there, locating it. If it's a patient in the ITU, you might have access to point of care ultrasound, which is very useful in the obese patient in locating your cricothyroid membrane. So remember to, if you're trained, which we try and train all our trainees now doing ultrasound to locate your cricothyroid membrane, so you could have that there immediately available to locate your cricothyroid membrane, extend the patient's neck and prepare in case you do need to do a front of neck approach, having perhaps given a muscle relaxant to attempt to intubate. I think, I can't remember whether the patient you said, Professor, we had limited mouth opening or not. I can't remember the scenario.
Which one?
The last case that the hypothetical scenario you mentioned earlier.
Yeah, well, that's probably difficult to answer. But in our hospital, in this situation, probably we have called a rapid airway, a rapid emergency airway. Those are not just anesthesia. The EMT will come for front neck. So if we do that, so the whole team will overheading, then the EMT come, then the anesthesia team come. Anesthesia team typically do the intubation. But if you had kind of open the mouth, we can do the intubation that's clearly obese and desetting, clearly a front neck. So probably we will manage to give oxygen, whatever the way you have. Probably most likely the mask can ventilate patient and try to keep or the oxygen level to not to bring that level, then ENT will do emergency airway. I don't know what other hospital, whether you do it or the the ENT come. The muscle relaxant, that really, I think that the trend for different airways try to use muscle relaxants rather than refuse it. The situation is this patient is morbid obese. Generally, if you give a muscle relaxant, increase muscle ventilation by success by 3-fold, increase intubation success by 11-fold. So generally, I think muscle relaxant is probably most likely help you to ventilate patients and to keep oxygen level not to the brain gas level. But the question is, after you paralyze patient, you have to be able to ventilate patient to maintain oxygenation because patients lose spontaneous ventilation. But I think that if the patient comes to the level and you feel that continuously going during their emergent tracheostomy or emergent cardiac technique to the brain gas level, I think we should use muscle relaxant and the mask ventilators. Most likely it will increase ventilation, increase oxygenation. You just need to maintain that oxygen level until the tracheostomy, until the emergent airway is performed. That's my thinking. Thank you.
Can I jump in there, Huafeng, with a couple of ideas just around this situation that you posited us, which is a patient on the ITU with a failed airway who is obese. I also wasn't clear from when you asked the question initially if you had imagined this patient have limited mouth opening or not. So I've broken my thoughts around it down into a limited mouth opening column and a not limited mouth opening column. And I think what I find interesting is when one looks at the literature, the contribution of obesity to difficult airway management is clearly shown in the pre-hospital and the ICU and the out-of-theater literature, and is much less well shown as an independent factor for difficult intubation in the operating theater setting. And I think in my mind, this is easy to understand if you consider that when we position patients in the operating theater for airway management, we are usually meticulous in having them well ramped or external notch or flex tension or whichever term you like to use for the positioning that we achieve. Whereas when we manage these patients out of hospital or in the ED or in the ICU, we usually have a crashing patient. We manage them where we find them. So I try to remind my juniors and my colleagues that if you're in this situation and you're able to achieve any oxygenation, that positioning the patients before further intubation attempts may well be a very, very useful strategy. Of course, trying to achieve that in the ICU and the ward environment can be really difficult. So I think in a situation, if I were called to these patients, and frankly, we've been doing this a lot recently with COVID, I think our mean body mass index for our patients who've intubated with COVID-19, having failed their high flow nasal oxygenation therapies, has been 39 in my hospital. So we're seeing a lot of morbidly obese patients whose airways we're managing emergently. I think I would remind the staff who's managing the patient to try and continue oxygenation from the top. And that would be, I think, the first go-to would be a supraglottic airway in my mind if you don't have limited mouth opening, because the success rates with SGS for oxygenation are actually really good. Maybe you'll have a leak and your ventilation might not be great, but it'll at least oxygenate and save the situation. And then video laryngoscopy with a suitable bougie introducer is usually successful in these patients if the positioning is good. So I think I would say, get a mask on, two-handed grip, oral and nasal airways if necessary, go to a supraglottic, and then get the best handedness that's able to intubate the patient. With the limited mouth opening situation, now that's a lot more fun because now the supraglottic option is denied to us. I think if I was on my way up the stairs and I was on the phone to the people in the unit, I would be saying, try an oropharyngeal and or a nasopharyngeal airway together. So an NPA often quite successful. This circles right back to your suggestion about using the wave jet and on an NPA. Now, obviously, this is just using a standard nasopharyngeal airway. Somebody doing a very, very good jaw thrust, and then something which has been successful in a setting, and I'd be interested to see how often it's used internationally. I'm quite a fan with limited mouth opening if you need to do emergent intubation of using an optical or a video stylet through your tube. And one can often be successful with something like a Bonfils, a Shikani, a video stylet, even when you've only got about a centimeter of mouth opening. So those are some ideas. SGA, if you can get the mouth opening, and then rescue by your favorite technique. If you can't get the mouth open, a nasal and oral airway, and then considering if you're going to go for intubation, then not go to front of neck immediately, trying a rigid scope.
I agree with Ross with regard to the Bonfils. I use it a lot. I use it a lot for limited mouth opening with pharyngeal lesions as well, because the tube is on it. There's a new one which has got a levering device at the end, but I still have the older rigid one, and it works very well, and you can oxygenate down through it. However, it's not in widespread use, even in my department. There's a learning curve, which I think it's not the sort of thing you should just take out in an emergency. You should use it in elective cases to practice. And a number of us do that, but there are some other people who find it quite a tricky technique unless you're experienced.
Thank you, Ross. Thank you, Alan. Professor Wei, it's 8:30. Shall we end the discussion?
Yeah, I recommend I'll stop recording, and we also stop the live broadcasting. Those are probably major audience in China. I see how many website. So with about 6,023 audience watching this live broadcasting, and yeah, that's the how many people are watching this video. 6,023 audience. Those probably majorly from China and also probably from other countries. I want to, yeah. I will stop the recording here. I recommend you're free to leave, and for those people in use and you want to chat, not on this, and just meet each other as making friends. One of the purpose for this series is let's make friends and know each other. So when we have really like what we met meeting led by Ellen, then we know each other early already. We know who are we. So I'm gonna stop recording.